Well, it's 2 o'clock in the night. Just imagine you are the only duty doctor sitting in the emergency room. Suddenly, you hear a screech of tires, a loud noise outside the room. Within minutes, a young man is brought inside the emergency, bloodied, unconscious, with mangled limbs, no clear airway, hypotensive, and with no family in sight. You have just 30 seconds to make the first decision that could either save or cost his life. Yes. So, what do you do first? Where do you look first? Who do you call? How do you stay calm when chaos erupts all around you? Well, this is polytrauma, my dear friend. In this video, let's discuss how to manage a case of polytrauma, not just with knowledge, but with clarity, speed, and with confidence. Because when the systems fail, the protocols guide us. When the seconds matter, our mindset save lives. So, uh, in this video, let's learn the basics of trauma management as per ATLS protocol. So, what is polytrauma? When someone suffers traumatic injuries which affects more than two systems or organs, then it's called polytrauma. Okay, someone uh, traumatically injured, okay, more than two systems or organs injured, called polytrauma. So there are two words which are used interchangeably. Trauma scenarios. One is multiple casualty, then another one is mass casualty. So when there are multiple injured patients are there, when they come to a center, a PHC, district hospital, tertiary care hospital, wherever, when they reach the center, if there are adequate resources are available to manage them, then it's called multiple casualties. If the patients are overwhelming the resources present, then it's called mass casualty. It can be PHC, CHC, wherever there is a the patients can be well managed within the resources of the manpower available. Then it's called multiple casualties. Whereas if they can't be managed, they have to be referred to some other centers to manage because of lack of resources. Then it's called mass casualty. So such a scenario of mass casualties, we have to prioritize the patients for treatment depending on the severity of injury, likelihood of survival, and urgency of care. These factors we have to prioritize the treatment. This prioritizing is called triage. It's called triage. Okay, the literal meaning of which is to sort out. So we go through all the patients and tag them, tag them who requires immediate attention or who are suffering from immediate life-threatening injuries are labeled red. They need emergency resuscitation and interventions. Those who are not at immediate life-threatening injuries, they are tagged yellow. They also need urgent resuscitation and intervention, but not so life-threatening. Those who are injured, but they are not at risk. Okay, they even the delayed management also sufficient in such scenarios like walking injured, some lacerated injuries, or the small fracture cases are labeled green. They for them the delayed treatment is also sufficient. Those who are moribund, dead, or pulseless patients are labeled black. So the entire process of triage and management can remember by the mnemonic SALT, SALT. So S for sorting out, then A for assessment, called primary assessment, secondary assessment. We'll be discussing it further. So to assess and then do the life-saving treatment, do the most needful things first, and then decide whether you can give the definitive treatment in there itself, or you have to transport or refer them to a higher center. Okay. So SORT, sort, assess, life-saving treatment, and then transfer or do the definitive treatment. Well, transferring or when before giving the definitive treatment, you have to ask the patients called, you can remember easily by the mnemonic ample. Patient, you can ask for any history of allergies, any other comorbidities patient suffering from, any past history, any significant past history, when he had the last meal. That's very important to for the intubation purpose, and what event led to this trauma, other things, or if the patient is unconscious and all, patient not be able to give any history, then you can ask the responder, the primary responder or driver who brought him to the center, or the bystander, go to the missed. M for mechanism of injury, I for injury sustained, S for signs and symptoms what he had when he came to the initial setup, or the treatment he received, how he was transported here. So the things missed, you should ask from the responder. Then most commonly asked MCQ, what is the golden hour? The first hour after sustaining trauma, first trauma considered to be golden hour. Okay, don't get confused between a golden hour of trauma and golden hour of injury. For suturing, it is 6 hours. Hours, golden hour, suturing. Okay, so let's come to the ATLS protocol. How do you assess the patients? Something called primary survey and secondary survey. We all know this. In primary survey, we give focus to the most important or vital things. You can easily remember by A, B, C, D, E. A for airway with, this is very important. Not just A for airway with restriction or protection of the cervical movement. Okay, this is very important. And B for breathing, which includes the ventilation and oxygenation. C for circulation with hemorrhage control. D for any disability like neurological examination, and E for exposure. And in the secondary survey, we do the elaborate or in detail examination of the entire head to toe examination. Here, don't get, we usually in India we follow American guidelines, American trauma life support protocols. Whereas in some of our books, or some of you may get confused by another protocol, that is CABCDE. Okay, control of exsanguinating hemorrhage, C, or sometimes okay, written as NICE guidelines or Bailey and Love and all. It's UK. They mainly follow this. First control of the bleeding, then ABCDE. But usually in our setup, we follow American guidelines, that is ABCDE. Control of hemorrhage comes in C. Remember that. Don't get confused. And A includes most important, most of the questions, everything related to this A with cervical spine restriction, the cervical movement. So one thing we should know, which is highlighted in all the ATL's protocols, guidelines everywhere, is what are the life-threatening conditions. They are, first thing is airway obstruction. Second is any tracheobronchial injuries. Third, the two things related to the breathing. These two are related to airway. Then two things related to breathing is tension pneumothorax and open pneumothorax. Then there are things related to circulation, massive hemothorax and cardiac tamponade. And then there is also traumatic circulatory arrest. These 7 things are immediately life threatening. We have to intervene within minutes or else lose the patient. These are the 7 conditions altogether. Should be very careful about. Okay, how do you go about now? Okay, there is a patient who has come, then we should be well prepared, well equipped. Scene safety is the first. Can't do anything risking your own safety or your own life, right? Scene safety first. Everything aside, the patient should be there and check for his response. Knock him or ask him, is able to talk or not. Then immediately call for help, because you can't do everything all alone. You have to get help of others also. When you are checking the response, if patient is talking, then that means his airway is intact. Okay, airway is intact if the patient is talking. So then you can go for B, breathing. Then you can connect a oxygen mask, airways patent. So just maintain the airway by giving oxygen, and you immediately, second thing what you do is the collar and restrict the cervical spine movement. Then go for B, that is breathing. If the patient is not talking, then it could be due to there's a compromise in the airway. That's one of the common causes. There are other causes also. So how do we know that really he is unconscious or airway is compromised? Use of accessory muscles for respiration. Accessory muscle or intercostal muscles for breathing. Snoring, any gurgling or hoarseness in the voice, or any strider. Okay, all these are suggestive of airway compromise. There is a cyanosis because oxygen is not entering in, so desaturated. Cyanosis is late sign of airway blockage. These signs are there, then you can confirm that there is a airway problem is there. So immediately you have to secure the airway. Immediately you have to secure the airway by removing. First thing what you can do is try to open the mouth or nose and remove any foreign bodies, any vomitous present, blood, if any, you can suck it out. Okay, if it still persists, then don't go to do anything much, because you are concerned about the cervical spine also. So first thing you have to, before managing the airway, just you assessed before the managing, you have to protect the spine, or else spinal just movement like this may go into spinal shock. You may lose the patient if you clear the airway. So you have to protect the cervical spine by what is the method is called MILS, manual inline stabilization. Okay, one person, see, just like it's shown in the image, one person has to hold in line with the body. Okay, then maintenance of the airway after holding the spine in position. Okay, then you can maintain the airway by two maneuvers. This is a commonly asked question. What are the maneuvers to maintain the airway? One is chin lift, okay, and one more is jaw thrust. Chin lift and jaw thrust, two maneuvers to maintain the airway, and then give the once the airway is secured, then give oxygen mask. Then you can't keep on holding the patient, right? In manual stabilization not possible. Then give a cervical collar. It's called Philadelphia collar. Just like this, you can see Philadelphia collar with the opening here for any airway to secure the airway. There is a hole in the collar. Okay. Once you secure the spine, then you have two options. Okay. One is, because anyway again it may airway may collapse. You have to secure a definite airway. If not available, then you can go for adjunct airway. So definite airway, the form of intubation, orotracheal, nasotracheal. Usually we don't orotracheal intubation. Okay. And minimum three people are required to one, because one to hold, two people to intubate. Okay, and if it's not possible, you can try second time intubating. Second time, this is also fails. The second time intubation also fails, then you have to go to something called emergency cricothyroidotomy. Throat cartilage, there is a cricothyroid membrane is there. There put a wide bore needle. Then you directly secure into the airway. Then you can connect the oxygen to it. Okay. That's emergency. Then later on, once the patient is stabilized, resuscitated, then you can do definitive tracheostomy. Tracheostomy. If definitive airway is not available, then you can use some adjunct airways. Adjunct airways, or the patient is not having an apnea, or saturation is less than 85% on O2, on GCS is less than or equal to 8. These are the indications for airway. Adjunct or definitive. For definitive available, go for definitive, or else you can do adjunct with the oropharyngeal airway. Oropharyngeal airway. Then you can go for breathing. questions asked, what is the sequence? Uh, the airway management is first airway assessment of airway. Then second step is cervical spine protection. Cervical spine protection. That's the second thing. The collar. Then third comes the maintenance of airway, whatever the adjunct or the definitive airway we want to secure. That's only after protecting the movement of the cervical spine. Hope it's clear. Okay, this is the sequence. Then once the airway is maintained, then only go for breathing. It's not first you assess the airway, then go to breathing. No, after clearing up, only then go for the second one. Once airway is secured, then second one is breathing. Breathing mainly look at the chest movements and breathing rate and breathing type. Any abnormalities are present. What the main problem with breathing can happen is mainly pneumothorax. Any trauma, chest blunt trauma or penetrating trauma can lead to pneumothorax or hemothorax. There are some distinct factors clinically to help you to immediately conclude what you're dealing with and manage accordingly. So in all the any pneumothorax or hemothorax, respiratory rate will be increased. You know, tachypnea will be there, and the massive hemothorax and all because of loss of blood is lost. They may develop hypotension. JVP will be usually elevated in case of tension pneumothorax. Okay, whereas it will be decreased in massive hemothorax. Mainly, how you can distinguish this simple pneumothorax and simple hemothorax are not life threatening. What's life threatening, as we saw from the list, is tension pneumothorax and massive hemothorax. How can you really distinguish it? By just one percussion. Pneumothorax, it will be hyperresonant. Okay, right? It will be hyperresonant note you will get. Whereas in the massive hemothorax, there will be dull note. And breath sounds also. Breath sounds can be absent or diminished in both. Whereas classically, with percussion note, you can distinguish between hemothorax and pneumothorax. And if there is a pneumothorax is there, immediately needle thoracostomy you can do. Nowadays, in the recent 8 years guidelines for adults, earlier it was in second intercostal space. Now it is recommended in fifth intercostal space, where you put the ICD. There only you do the needle thoracostomy. For children, it continues to be in second intercostal space. That is for emergency. Later on, definitive you can do intercostal drainage insertion. So pneumothorax, there are three types mainly. Theory aspects you know very well, like closed pneumothorax, open pneumothorax, all those things. I will not go into the detail. See, this is how it looks like. Okay. In X-ray, when you take a X-ray, tension pneumothorax, see, the left thorax is filled up with the air, and the viscera, trachea, heart, everything, their mediastinal structures have moved to the opposite side, to the right side. This tension pneumothorax with mediastinal shift. Here, this pneumothorax is there, but it's not tension pneumothorax. Yeah, simple pneumothorax maybe can develop into tension pneumothorax later on. Here you can see the hemothorax. Here the fluid column is there. Hemothorax, left-sided hemothorax, massive hemothorax is. These are pneumothorax. The lung borders can be well visualized, and this is the air. Here also see lung border means air. So simple pneumothorax. So this is the one question we should know. Where do we put the ICD? That is the triangle of safety. The borders of which are anteriorly you have lateral border of the pectoralis major muscle. Posteriorly you will have lateral border of the latissimus dorsi. Okay. Base is formed by, this is a triangle. Base is formed by the 15th base. So this is the area where there are no major vessels or nerves, anything safe for inserting any tubes. So in the fifth intercostal space or in the fourth intercostal space, you insert the intercostal tube. That's the question again is, where do you insert in the intercostal space? You put at the upper part of the intercostal space, not lower. In the lower part of the intercostal space, there are intercostal nerves or everything passing. So not to damage that, put at the upper part of the intercostal space or the lower part of the lower border of the rib. Hope it's clear. Okay. And you You insert the accordingly. If there is a hemothorax, you put it downwards. If there is a pneumothorax, you put it upwards, the drain. Then you connect it to a underwater seal drainage. Okay, you can confirm whether it's in position or not by the fogging of the tube, and also when the water column, see, when sitting inside, when you connect it to a water seal drainage, water column will raise in this. Column will raise. The water will, when you breathe, water column will raise. When the patient expires, it will come down. Okay. The area of triangle of safety bounded by pectoralis major, latissimus dorsi, and latissimus dorsi and fifth intercostal space. Hope it's clear. And when do you do emergency thoracotomy? Okay. Thoracotomy. When you insert the ICD, immediately more than 1.5 liters comes out. You have to take the OT to the emergency thoracotomy. Or more than 200 ml of blood comes per hour for consecutively for 3 hours. Or if there is a suggestive of features, cardiac tamponade is there, or if any features of esophageal injury is there, or on X-ray if there is a mediastinum widened more than 8 centimeter, or if there is a persistently collapsed lung even after aggressive positive pressure ventilation. These are the indications for emergency thoracostomy. Okay, you can do left anterolateral, or that is in the 5th or 6th case you can do the thoracotomy. Okay, once you manage the breathing, if there is abnormal pattern of breathing, anything is there, you suspect to be some lung injury, maybe pneumothorax or pneumothorax, you manage accordingly, and then only go to the C, circulation. Circulation, any trauma patient, most commonly we can expect some blood loss leading to hemorrhagic shock. My dear friends, always expect one question from this slide. Any exam, one question. There are 4 classes of hemorrhagic shock: class 1, class 2, class 3, and class 4. The different features of each you should know. In the class 1, usually it's called compensated phase. Body will try to compensate the blood loss by some or other mechanisms. Okay, then class 2, class 3, class 4 are mild, moderate, or severe hemorrhagic shock phase. So in the compensated phase, the blood loss is less than 15% of the blood volume. The class 2 is 15 to 30, 30 to 40, and more than 40 class. In the compensated phase, everything is overcome, like heart rate is maintained, no tachycardia, or in the class 2 there is mild tachycardia, 100 to 120, 120 to 140, and more than 140 in class 4. Similarly, the blood pressure, see, up to class 3 maintained. Class 3 onwards there will be hypotension. Similarly, pulse pressure also maintained in the class 1. Class 2 onwards pulse pressure decreases. Respiratory rate also maintained class 3. In class 3 only they develop tachypnea. Urine output also starts dropping because the tissue blood loss is more, tissue perfusion is less, urine output is decreases from class 3 onwards. And Glasgow Coma Scale also, when the blood supply to the brain decreases, so they slowly become unconscious slowly. Okay. Class 3 or class 4. And base deficits, if you take an ABG done, so base deficits will not be seen in the class 1, class 2, class 3, class 4. There is a base deficit there, and usually in class 1 they don't require any blood transfusions, just monitor, it's enough. Class 2 they may require, class 3 definitely they'll require, whereas in class 4 massive blood transfusion. You know what is the mean definition of massive transfusion required in class 4 hemorrhagic shock. Okay, so how do you manage? First, assess circulation. Okay, if there is an check for the pulse, BP, the saturation, everything, there is any features of these like what we mentioned, then immediately intervene. What do you do is, first thing is, this is very important statement here, to widest bore cannula, not too wide bore, which is the widest available in your setup. It could be green, it could be orange, it could be gray, which are the widest bore available. Not specified to green cannula only better, gray, no, whichever is available widest. Okay, the anticubital vein, that's also important. and both the decubital veins you put widest bore cannulas. Then if not available, sometimes in the patient is in shock, all the veins will collapse, you will not get the veins to cannulate. Then second option what you have is osseous. For part of India, you can directly into bone marrow. You can put the intraosseous cannula. Even then it's not possible. You can go for venous cut down, great FMAS vein or the brachial vein. You can directly cut down, directly insert the cannula into that. So then fluid of we have to start giving the crystalloids fluids. Fluid of choice is RL or normal saline. Best fluid, because immediately when the patient comes, whatever is available in the ward you give. Best, if they ask which is the best fluid for resuscitation, lost blood can be given is blood only. That is the best alternative for blood, right? Preferred is always cross match blood, always preferred, but for to properly cross match the blood it takes 45 minutes. The trauma scenario we can't wait so long. Most commonly used is the universal donor, that is O negative blood group. O negative blood group. Okay. So best guide, they ask, best guide for fluid resuscitation or tissue perfusion. Best guide of tissue perfusion, if they ask, is urine output. Correct? Urine output. The goal is to achieve 1 ml per kg per hour. The pediatric, more than 0.5 ml per kg per hour of urine output should be there. Adult patient, for example, the patient of 60 kgs, then minimum of 30 ml per hour, 30 ml per hour urine output is there, then it's adequate. Less than that, that means that he is hypovolemic. You have to increase the fluids. Hope it's clear. What's the amount of fluid required? How much to be given? Requirement of amount of fluid is best assessed by pulmonary capillary wedge pressure. Basic method to check, or simply you can do by the central venous pressure, CVP, central line. Okay, goes into the right atrium. Then you can check the central venous pressure. Then nowadays, earlier the dictum was we have to achieve the normal blood pressures for patient to survive. Nowadays we have understood that amount of hypotension is good, because when the patient is hypotensive, the bleeding is less. You have to maintain that mean arterial pressure, that for all the vital organs to survive. Need not be always achieve the normal blood pressure like 120, 130 and not required. So what is the concept is balanced or controlled or permissive hypotensive resuscitation is the dictum these days. Okay? Because little bit hypotension is good only. It decreases the bleeding. So BP just above 90 is enough. So like BP of just above 90 is enough, so that the mean pressure is maintained for the vital organs to get the blood. How do you maintain that pressure is by giving 1 liter of crystalloid, RL or NS stat. Earlier it was in earlier ATLS guidelines it was written 1 to 2 liters. Nowadays it's clear cut mentioned 10th edition onwards 1 liter of crystalloid. Okay. After that, if still the BP is low, then you can start transfusing blood or blood products. Always in the ratio of TRBC, fresh frozen plasma and platelets in the ratio of 1:1:1. And as per the crash to trial, ask you this also, crash to trial, it's the patient is having severe tachycardia, hypotension and all. There's a role of giving injection tranexamic acid, okay, 1 gram, okay, 1 gram stat, then every 8th hourly. 1 gram stat over 10 minutes, only over 10 minutes, okay, within 3 hours. Of injury should be given. So it stops bleeding, it controls bleeding, it's shown, okay. Then every 8th hourly it can be repeated. This is as per the crash to trial. So this one question in any exams, this has been asked, what is the gauge size, color coding of the cannulas, you should know. Color cannula and diameter is also asked. where it is used. This one slide you should know by heart. Okay. Coming to hemorrhagic shock, more things. Earliest sign they have asked tachycardia. In this slide also we have seen the earliest sign to appear is tachycardia. Hypotension is a late feature. Other signs are cold extremities, profuse sweating, altered sensorium, decreased pulse pressure. Then the maybe in the third stage or so will be hypotension. If the patient is stable, a hemorrhagic shock, but the patient is stable, then two wide bore cannulas you can secure, and then the maintain that blood pressure with RL. Then you can continue to the next one. The patient is unstable, that is BP is less than or equal to 90, then it's called traumatic circulatory arrest. Traumatic circulatory arrest. So in such a scenario, the patient is having severe hypotension. In such a scenario, the source of bleeding is known, or it's given in the scenario, or you can see in the limbs, the bleeding you can see. No such source of bleeding, immediately control the bleeding. You can put a tourniquet or put a pressure or something and stop the bleeding. Okay, and then start the IV line and do balanced hypotensive resuscitation. If not given as a source of bleeding, then it could be somewhere thorax or abdomen, we don't know still. Then start doing the balanced hypotensive resuscitation, then get the investigations done like a E-fast or X-ray, etc., and to know the source of bleeding, and then you can control the bleeding. Hope it's clear. A patient comes with hypotension, patient is stable, then you secure the two wide bore cannulas, then do the BHR. Okay. Patient is unstable, then do the bleeding control first, then simultaneously you secure the lines, cannulas, and do the balanced hypotensive resuscitation. That's all difference. Sources of bleeding can be, there is a saying in details protocol itself, it can be blood on floor or 4 more. The patient is there, emergency, and you can see the blood on the floor. That means that it should be bleeding from the limbs, means from external organs, limbs only. So blood on the floor means external bleeding. Just put the pressure over it, most of the bleeding will stop. Not then you can put the tourniquet, then you can explore and stop the bleeding, and then do the hypotensive resuscitation, balanced hypotensive resuscitation. The patient is, you suspect to have a bleeding in the thorax, that is in the form of massive hemothorax. Then what you have to do is immediately insert a chest tube, costal tube in that particular site. You can the blood will be drained out, the lungs will expand, he will breathe normally. If the more, like just we mentioned, if there is more than 1500 ml of blood as soon as we put the ICD, or more than 200 ml consecutive 3 hours, then we have to take it into OT and do thoracotomy, and then simultaneously a balanced hypotensive resuscitation. If suspect to be the bleeding source to be in abdomen, the patient is coming with any features of peritonitis, or in case of any penetrating injury, any kind of penetrating injury, you have to immediately explore the patient. Correlative laparotomy and simultaneous balanced hypotensive resuscitation. Remember, abdomen is the source of bleeding, and blunt trauma with peritonitis, or any kind of peritonitis is, or any kind of penetrating injury, you have to explore and see where is bleeding, and immediately you have to stop it. If you suspect it to be retroperitoneal bleeding, it could be because of pelvic fracture mostly. So immediately put the pelvic binder and start doing the BHR. If it is long bone fractures, that can also bleed a lot. Immobilize with a splint or something, immobilize that fracture, start doing the BHR. Okay, these are the 5 scenarios of bleeding, how to manage that. Patient can be in shock, but could be non-hemorrhagic also. Like it could be neurogenic shock. How do you distinguish is, will have hypotension, both hemorrhagic and non-hemorrhagic, but in hemorrhagic they will have tachycardia, whereas in neurogenic shock they will have bradycardia. In hypovolemic or hemorrhagic shock, they will have cold extremities, whereas here the vasodilated, here the warm extremities will be there in neurogenic shock. So the treatment is in crystalloids, along with that inotropes, vasopressors you can give neurogenic shock. The patient is in cardiogenic shock, like cardiac tamponade. It will have hypotension because of loss of volume is lost, and the heart is also not pumping effectively. Hypotension will be there. Increased, there's a lot of pressure on the jugular veins or the vena cavas to increase JVP, and the heart is not pumping effectively. So muffled heart sounds. It's called X triad, right? We know this. Okay, what we can do immediately is pericardiocenter. Episternum, there's a window, episternum, we can insert a needle and draw the blood out. So at pericardium, blood is collected there in the pericardium, will subside, so the heart can pump normally. Then immediately I would take him to the OT and do the pericardiotomy and evacuate all the clots, everything. Sometimes you may have to do the pericardiectomy also. Tension pneumothorax also, patient can have hypotension because of the lung is not involved in the oxygenation. So then you have to do needle thoracostomy and ICD for that. So the other possibilities of shock. Next, after you manage the circulation, then go for disability. Okay. In disability, mainly you do the focused neurological examination, not detailed, but mainly you check the GCS, pupillary reaction, and any lateralizing signs. The things you see. What are these details we will learn in the next class on head injury. I'll take. Then we'll discuss in detail about the GCS. What are pupillary reactions? What are the lateralizing signs, etc. Okay, these are about the neurological examination. Then the fifth component is exposure. You have to completely take out the cloths and completely examine him, and immediately you have to cover him back with blankets. Otherwise, he will go into hypothermia. Cover with warm blankets, prevent hypothermia. Maintain a temperature of around 39 degrees Celsius. And you have to even look at the back also, right? Back also. How do you look at that back? By a technique called log roll technique. So many questions on this. Log roll technique. There is a technique. Minimum of 4 people holding him, one on the head, 3 people in the body. Okay, they slowly roll back to one side so that their back can be spine, back can be examined. Even the correct examination can be done in this position. Question here are ideal people required for log roll. Minimum people required. They asked for. Remember this. So after primary survey, they'll ask you one more question in primary survey, that is, what are the tools or adjunct used in primary survey? Of A, what are you used for assessment of B, what are you use, like that, adjuncts or tools. Pulse oximetry we used, then ABG we have to use, ECG, X-ray for chest and pelvis. Okay, we have to use APV both in the supine position only. EFAS we used for circulation. Is there any bleeding in the abdomen? Foley's catheter we have used to check for the urine output, and Ryle's tube we have to put orally. If there is an injury, we'll come to know secretions, blood and all. These are the adjuncts, tools we used in primary survey. Please remember all those things because all except kind of questions they ask from this. Then there's something called damage control surgery and all that we'll learn in the next class. Head injury and abdominal injuries we'll learn separately because they are very big topics. GCS, everything in detail we'll learn in the next. So if you have any questions, please put it in the comment section. I'll answer them. Else, let's end this session. Very important entrance point of view, your clinical practice point of view, and it's very essential to know this also. This topic very interesting also, essential. So that let's conclude. Thank you so much.